But I'm going to talk a little bit about something I never expected or thought I would be involved in, and how we came to that, and our current project, and give some preliminary results of that. I think it's an interesting story. I've obviously lived it. I hope you do too. And I tried to make this as approachable as possible without getting too much into bug ecology, which I'm sure everyone would be excited to learn about. So as I said, I'm going to talk a little bit about the background, where I work, in case some of you don't know, how I ended up, writing the words climate change in some of my grants and then having to take them out on this renewal, the trial we're doing, and some of the preliminary data. And it's still really kind of right off the database. Standard declarations. This is the grant from the NIH up top that supports this work. I don't have any conflicts related to this. So where do I work in Uganda? Well, first of all, I work in Uganda, but where I work is sort of a unique area. It's called the Kasese district, is sort of the main district for our clinical sites, although we are expanding a little bit. And it's on the kind of southwest, extreme west of the border. It borders DRC. But it's really divided from DRC in a lot of ways, sheltered from some of the instability there by what's called the Ruwenzori Mountains. And they go up to 15,000 feet. They're not small. There's still some snow up on top there. And it's beautiful, really is beautiful. Most of my work is focused on malaria since I first started there, although we also have done some work on HIV and hepatitis, things like that as well. And increasingly, we've kind of switched to clinical trials as our main mechanism of doing research. One of the things that make this really a amazing site for malaria research is because up here at 15,000 feet, there are no mosquitoes. Mosquitoes do not like the cold. But as you come down that gradient and you get over into this area, this is Queen Elizabeth National Park. This is in elephants safari, right? Malaria, there's tons of malaria there. So you've got this natural gradient of transmission intensity, which makes it really neat because you can study places where there's very little malaria, almost like an elimination setting, to places where there's tons of malaria over a span of about 20 kilometers. And as you can see, it is strikingly beautiful. It is remote. It is the end of the dirt road and beyond. Okay. It takes us about 7 hours, 7.5 hours from Entebbe. It's a long ride, and that geography defines so much of everything we think about, whether it's the economy, whether it's how people access and utilize healthcare, schooling, transportation, you name it. And this is a picture that I took when I was first starting to work there, but it gives you a sense, like this is where people live up on the mountainside. And this is how they get down. And you can see, anybody know what this is that they're growing? It's coffee. It's Arabica. Coffee grows really well in places where it's sunny year round, never freezes, but is never too hot. If it's too hot, the bean actually gets, or the cherry as they call it, gets too much sugar too quickly, and the coffee doesn't taste good. Things you never thought you'd learn in medical school. But here's a woman carrying back on a baby route. That's kind of where the idea came from. And she's walking down. You can imagine doing that in the middle of the night with your kid who's having a fever and seizing. It's a challenge. This is a map that Paul made for us. And it's just looking at estimated walking times to a health facility, which are in yellow. And you can see as you get up again, lower elevation to higher elevation, as you get up along this border, and this is the Ruwenzori National Park, no one is allowed to live in there. So this is the boundary. But as you get up along these higher places, some of it's 1.5 to 2 hours of walking to get to a health center. It's a lot of work. And there are not good roads. So I first started working there in 2013. It just happened to be the year that really the first major flood. And much like we've seen here in the US, this was sort of described as a once every 50 year sort of event. And it was very devastating. Tens of thousands of people were displaced, and it happened after 2 nights of heavy rain. There's sort of a discussion that could be had, not worth having here, about why this is happening. And there's multiple factors, including land use and climate change, but really devastating flooding because you've got these rivers that come down from the mountains, heavy rain, it all comes down like a bowl into the lower lying areas. So this is the town of Kalembe. You can see here, this is after the flood, but a little bit over here, you can see like the dirt from underneath the house was washed out, right? I mean, total devastation. This is what was the road, and none of this rock was here. This has all come down from the side of the mountain. So what happens with flooding? There's immediate death, right? People get swept away, carried away. There's a lot of displacement. I think this one was, hard numbers are hard to come by, but I'm guessing, I think I had seen like 10,000, 20,000 people were displaced. The infrastructure, a lot of clinics, and the hospital in Kalembe was gone. It was totally wiped off the map. And then disease, and that's kind of where my interest lies. So just a quick refresher, and some of you may know Annika. Malaria is caused by a parasite that's transmitted by a mosquito. And anopheles breed in small pools of water, like the size of my palm. It could breed in a pool of water that big. And malaria mostly impacts children. Adults get malaria, but if you live in an area where there's a lot of malaria, you get repeated infections, you build up some immunity to the worst effects of it. You still get it, it's still not fun, but you don't die from it. Kids don't have that reserve, right? If a kid gets it, their immune system isn't protecting them very much, and they don't have their organs can't respond to an infection. So almost all the deaths are in young children. So this really got me asking the question of, does this flooding impact malaria? And I was hearing some of that on the ground from staff at the clinic where we worked. But, the flooding had happened. I had just kind of arrived for the first time the year of the flooding, and we really didn't know. There's not great studies on this. And so what I wanted to do at that time was just use the data that I could get, and it was all retrospective because the flooding had already happened. But we were able to collect data from the clinics from a year before to a year after the flooding. And then we did what's called a differences in differences analysis. I don't know if folks are familiar with that. So here is that sub-county that I showed you the pictures of. And we kind of broke the visualization, and you can see the elevation quartiles. Again, sort of left side being higher elevation up towards the mountains, and the right side, the red, being the lower elevation. And you can see the rivers, the major rivers kind of flowing through that area. So in the year before this, we looked at something called the Plasmodium falciparum parasite rate, which is basically just saying what proportion of malaria tests that were done at clinics were positive. Okay, that's all you really have to know. And in the year before the flooding, this kind of makes sense. Most of the positives were in this low-lying area between the rivers. And you can see some, at a lot of these clinics, half of the tests that are done are positive. If I had half the tests, if anything, in my clinic that were positive, I would be worried about an epidemic of some sort. And then as you go up the hills, you see less positivity. Well, what happened after the flooding? So in the year after the flood, you can see it got worse everywhere, basically, is the summary. But if you kind of subtract out and look at where the differences were, the change, what's kind of interesting is some of the biggest relative change happened in those higher elevation areas, which was unexpected. We didn't really expect that to happen. And so got some help from a professor here, Larry Band, who's no longer here, but had a lot of GIS and water sort of hydrology experience and helped us. And we mapped some of this out. And one of the things that you notice is that in those higher elevation areas, you've got like a stream bed. Most of you have seen a stream. And when it rains normally, light rain, all the water moves to that stream bed and moves downhill, gets handled. But when you get these huge events, it overwhelms those small stream beds and you get water that scatters until outside of that little stream bed. A couple weeks after that water settles in and gets nice and warm, mama mosquito comes along, lays her eggs, boom, right? And so that's probably why these areas that were relatively sheltered from malaria normally experience such a change after the flood. And how was the impact? I call this my rubber ducky graph. But if you look in the year before the flood, kind of seasonally, what happens, and Uganda has sort of 2 wet seasons, and the malaria kind of follows with that. So the flooding happened in May. So in the year before, we kind of see this peak in the dry season because it carries in from the previous wet season. Then it starts raining. And we usually see malaria go down when the rain first starts because it washes out any breeding sites, right? And so all the larvae die. So you see it go down, then it rains, they start to breed, it gets high again in the dry season. That's a normal pattern for malaria. What we saw in the year afterwards is it goes up in the same pattern, but it doesn't come back down. It's probably because there's so much residual water still available for breeding. And look how long that lasted. If you look at sort of the comparison, you still see a significant difference of having a positive test out to the next February, almost a year later from the flooding event. That's a big difference. And again, this is sort of the difference of differences analysis where you can look at the year before and after. And what you see here is like if there was a flood affected river before, if there was a river there before the flooding happened, you see them kind of crossing, you don't see a lot of difference. But in the year after flooding, you see that villages that had a river that was affected by the flooding are different. Okay, same thing here. Prior, you see that downstream villages have higher rates of malaria in the year prior, but after the flooding, they mix, you don't see any differences. So this was really cool, great, made for a great paper. And I was kind of like, well, done with my climate change, flooding work, really fun analysis, learned a lot. And then it flooded again. And this time, I really didn't feel like we could just repeat the analysis. And it actually had flooded a number of times in between 2013 and 2020, but not as severely. Almost every first week of May. And so this time I talked with my team and I kind of said, well, what can we do? Right. And this had happened during COVID, as you might imagine. I was at a career development award at K23 that was active in Uganda, but sort of paused because of COVID. And we wondered, could we actually try to do something instead of just measuring malaria change during flooding again? So we said, let's see if we can actually impact this and do something about it. So we very quickly put together a trial, a very small trial, but just to see if we could develop a concept. And we said, let's pick an area that was flooded and do chemoprevention. So this is something that's gained quite a bit of sort of mainstream. It's recommended in guidelines now for some areas, but basically you give children a malaria drug empirically. Go out, village, give all the kids of a certain age an anti-malarial. We tend to use one called dihydroartemisinin piperacin. Won't be asked to spell that because it has a really long half-life. So not only does it treat malaria parasites if you just happen to have them, and you can have malaria parasites and not have the disease for a while. So it'll treat that, but because of its half-life, it also protects you for almost a month from getting malaria. And so they do this in some areas of like North Africa and the Sahel, where malaria is limited to like 3 months of the year. Give it to the kids during those 3 months, nobody gets malaria. It's not recommended generally in high transmission areas where malaria happens all year because you just be giving out medicine all the time. So we said, let's do this for 3 months, because that's when we saw that when we expect the mosquitoes to lay in the water, come out, transmit. And if we can protect kids during those first 3 months, maybe we can sort of make an impact on the sort of epidemic of malaria that happens after flooding. As a comparison, we picked 2 villages as controls that were similarly affected, and then we looked at the malaria cases that happened in clinic. And so what you see here is a little girl. She's getting weighed on the scale because DP, as we call it, dihydroeromycin paraquin, is dosed by weight. And so she's getting weighed before getting her dose. She's getting a snack as well to make sure she doesn't throw up. And so what you see here is this is one of the areas that was flooded. And the green area, Zinga, is the village that we picked as our intervention village where we were going to do the prevention. And then the other 2 were the controls. And you can see they were neighboring, also affected, both of them. I mean, Azinga is almost like an island between these 2 rivers. Kakindo is sort of similar. So what did we see? Well, first of all, it was well tolerated. Everyone did fine. That was not unexpected. Acceptance was great. I think we were able to reach about 80%, 70 to 80% of the kids. And we saw significant reductions in malaria. You can look at this if you want. This is much more interpretable, I think, and you can basically figure out what's going on. So green is Azinga. That's the village where we did it. The other 2 are the controls. And what you can see in the controls is what we expect to happen. Malaria is going along, flood, bam, this peak of malaria cases. Same thing in Kanyanamingo, kind of this out to 2 or 3 months, you really see a surge. What you don't see is it happening in Azinga, right? And so here's each month where we gave a dose. Okay, worked. This is the obvious one. So this is kids under 12. That's who we targeted for this intervention. You can see it worked really well. What was super cool is these are people who are over 12 who did not get the medication, but there was less malaria. It was significantly less, actually. So you've got an off-target effect, basically, right? And why is that? Well, all those kids in the other villages, they get infected with malaria, and suddenly they're a reservoir for all those mosquitoes who are not infected, who come along and pick up malaria from those kids. So you're basically clearing the malaria parasites out of the population, which means even if mosquitoes do come around later, they don't have any parasites they can pick up from the kids. That was really cool. So here's a potential response to flooding. From a geographic standpoint, this was some work that Varun did for us. And what you can see is basically the outlines of it. This is Azinga, the village where we did it. And this was before the flood. In this sort of imaging, the pinkish color is water reflectivity, basically. So you can kind of make out the 2 rivers. So before the flooding, what you're seeing here is it's actually kind of hard to make out the rivers. And that's probably because there's a lot of vegetation kind of leaning over them. And then the flooding happens. This is about 1 month after the flood. And you see how much wider those areas are. And particularly up in the northern part, where I put the red box, which is where sort of 2 rivers spread apart. And what you can imagine happened during the flood is the water just subsumed that entire area. And then it remains that way quite a bit. Now, what's interesting is that this is clustering of malaria cases in the village. And what you see is this northern area remains sort of most impacted where that flowed over. You guys probably aren't old enough to remember the A-Team, but there was a guy on the A-Team, which was a TV show. He always said, like, I love it when a plan comes together, right? So it's great when your data actually fits your hypothesis. So again, what do we do about this? This was not what I thought my career goals would be, addressing flooding and humanitarian crises. I've been in the Army. I've been shot at. I really don't want to be in crisis situations anymore. Like, I'm really happy doing stuff that's calm and peaceful. So I didn't think I wanted to be in humanitarian emergencies, and I never thought that that's what I would be doing in Uganda. But what to do about this, right? This flooding wasn't going to change. It kept happening so predictably. And there weren't really guidelines. What would happen is the government would respond a couple of weeks later. They'd set up some tents around sort of the district headquarters, and people would move into those. They'd try to get the clinics reopened, but that was about it. There was not much else done, and there was no sort of guidelines. And this happened around the time, you may recall, there was terrible flooding in Pakistan, and they had big surges of malaria. And so I kind of thought maybe we should actually try to generate some more rigorous evidence about how to respond to these types of events and learn more about how malaria impacts them. So that was the basis of this R01, which we were fortunate to get funded. And I would say a big part of the sell was convincing the reviewers that it will continue to flood at our site. And again, I'm not put the aims up there. Basically, does it work, right? That's what we're doing. Can you prevent malaria after flooding? This next slide's more important. So it's a cluster RCT, randomized controlled trial. A cluster in our case is a sub-village. So every village is anywhere from usually 200 to 300 homes. But there are 5 community health workers in each village. They're called village health teams. They're elected by their community members. Officially, they're like level 1 government health workers. And traditionally, they've done things like health promotion. Pregnant woman, go to the hospital to deliver your baby. Better outcomes. Wash your hands during COVID. Or there's been an Ebola case in the neighboring sub-county. That sort of stuff is what they've done. But they're each responsible for about 1/5 of the village. And they have their own sort of contiguous areas of households. So we took the area of 1 village health worker as our cluster area. We then randomized them by river valley. We took 3 rivers, and then the baseline malaria transmission intensity. And what we wanted to do was test 3 different arms. So in one arm, we would just top them off with bed nets. That's our control. Okay. At best, that's what sort of WHO guidelines say you should do after a flood. Make sure everybody has bed nets. Of course, if you are displaced and you have to live in a tent, you can't hang a bed net, right? Or if you have to sleep outside, you can't use a bed net. Then bed nets plus the chemoprevention, the dihydroartemisinin and piperacin. And then bed nets plus chemoprevention plus BTI, which is a biological larval control. So it's, if you've ever been to like Home Depot and seen mosquito dunks, they're these little bits you can put in standing water and it kills any mosquito larvae that are in it. Okay. It's good for about 2 weeks, but the sun degrades it. But we wanted to give households packet of BTI with instructions to apply it to any standing water within an area of about 50 meters around the radius of about 50 meters around that. We wanted to compare malaria incidence between those 3 arms. So this is just sort of a general timeline. So you can envision we would do sort of our baseline surveys before the flooding. It would flood when we said it would flood. Then we would follow up at 1 month. Everybody would get bed nets in each arm. 2 of the arms would get the chemoprevention, 1 would get the BTI. Follow up at 2 months, 3 months, and then just longitudinal visits after, kind of compare between them. Sounds good. So we got out in the field kind of earlier this year to do our baseline surveys. I think it was actually before March. But just trying to get our basic data. I'm showing you this, although it skips ahead a little bit, just to show you where our clusters are located and how they're distributed between arms. Verona made this map for us. So you can see it's along these major rivers. Most of what we had done before was kind of in this area. So these were new areas where we had expanded to. But ultimately, we achieved pretty good distribution in our randomization. And I don't mean to kill you by tables here, but this is very preliminary data. This is sort of, we're still digging through a lot of this. But you can see it's actually a pretty big study. So we've got about 1,100, 1,200 households in each arm. There's 5 people in each household. You can do the math, but it works out to about 3,500 people in each arm. Like a lot of developing countries in Africa, a lot of the population is under 18. Not totally surprising. But we did achieve pretty good balance between the arms, between the river valleys and things like that. So again, still looking at some early data from this initial survey. One of the things that I like to point, or I found striking, is like households who had a child who had to stay overnight for malaria in the last year. 25%, roughly. That's bad. Can you imagine if 25% of kids here had to be in a hospital overnight? And then more than 1% had a child who died of malaria. Yeah. And then you can see the time to the nearest facilities. That's, I was just recently pulling some of this and I was pretty struck by it. So what about bed nets? Because that's still an area where I'm very focused on right now is malaria prevention. So shockingly, less than half of the households had any net. So if you don't know how this happens, usually the government distributes nets on a cycle of every 3 to 4 years. And that distribution happens through various ways. In our areas, what they do is the district headquarters, there's a lot of sort of push from the national ministry to the districts. The districts get the nets. They give the nets to the larger health facilities. Then the village health teams, the community health workers come to the local clinics, pick up nets, and are supposed to distribute them to the households. And this is supposed to happen every 3 to 4 years. This had happened only a year or so before we were out in the field. So that's not great. The goal, the WHO goal is that there should be 1 net for every 2 household members. So universal coverage is defined as if you've got 6 people in a household, you should have 3 nets. So we only had about a third who were at that. Almost all the nets came from the government. Nobody buys nets. And then only about a third of children had slept under a net, and 2/3 of those, because we inspect them, had holes. That was pretty striking. Interestingly, when we map out the clusters and sort of what their coverage was, this was some work done by a master's student who's presenting at a conference next week. Sarah Albana, thank you, she's in your class. So we looked at, we just made quartiles of clusters that had relatively high coverage compared to low coverage of their nets. And I haven't figured this one out yet. But if you look up here in this river valley here, they're really good. But this one really struck me because the district headquarters is right here. So I don't know. This area is kind of difficult to access, so maybe that explains. But is it bad house counts? Is it just not well thought out? Is it that there's definitely something you have to account for in net ownership and use is if you live in an area up high in the mountain, you could care less if you have a bed net because it's cold, there's not mosquitoes at night, right? So maybe we don't have many of those villages in our study, but you do have to think that sometimes people who live in really high malaria transmission areas are more likely to use a net, maybe more likely to buy a net of their own, whatever it may be. Could that be playing some role? I heard a little bit from my staff and from some locals that sometimes there's diversion of nets. They may ask for a certain number or, whatever it is. And I don't know all the details. It's a hard thing to prove, but something's going on with net distribution. And I don't quite fully understand. we should have fixed that in all those villages, right? We brought every household up to full universal coverage. Man, we had to buy a lot more nets than I thought. Now, this is also what Sarah has done, and just thinking about nets is, so of the households that were at universal coverage, so they had one net for every 2 people. The kids who were positive when we went around and tested them, only about 1.5% of the kids were positive. If you're not at universal coverage, so you don't have enough nets for everybody in the household, and you don't have any holes in your nets, you're at 1.8. It's probably not that different. But if you got holes in your nets, 3% of kids. If you didn't have any nets, 4.5. Makes sense, right? Again, it's nice when the data actually makes sense. So we are measuring a lot of other things. Elizabeth Frankenberg is on this study with us. And Sean Silva is on this study with us from the economic side. So, you know, there's a lot of stuff in here that we have not even begun to dig into. And so I just pulled some stuff literally right off the red cap to kind of look at this. So I thought this was pretty interesting, and there's a whole bunch of questions related to PTSD and mental health. And I will say that Uganda, I'm not a psychologist or a psychiatrist, but is not a country where you'll hear a lot of talk about anxiety, depression, mental health problems, at least in public. It's trying to change, and there's efforts being made, but I was actually pretty surprised to see 5% saying very frequently, 8% saying quite a bit from the flood. Yeah, it's not something I thought, and I'm glad we asked. And then if you think about some of those events and experiences that may have prompted that, looking for your family members, certainly traumatic. Seeing bodies, that's like 10-16% of people having to deal with that from the flooding. And with this happening every year now, it's sort of a repeated exposure. And I think that some of that's only going to kind of drive things. I mean, I know from military side, one of the things is the repeatedness of it can really drive problems. So as we've been going through this and kind of moved into some, as I've been out in the field with the team and the team's been out in the field, there's been some stuff that I hadn't initially planned for, but has come up as anything. So one of them that, you know, I don't know if folks are interested here, but one of the river valleys up in the mountain are mines. And it's old copper and cobalt mines. They've been shut down for decades. China recently bought them and is planning to restart them. But this is one of the rivers you can see where as it curves, when it floods, it's just been eaten away there. And it's kind of hard to see in this picture, but this entire area is yellow. And it's probably spall from the mining that's being done upstream. It's all getting washed down, or decades of mining that happened for years and years and years. And as we were talking to some of these communities, they were expressing concerns because this is where most people get their water, it's from the river. We haven't looked into that at all, and I don't. Yeah, it's just total. You learn something new every day, raises new concerns. I call this industrial risk. So you see this is actually water. It's kind of a swamp. We went out to one of our households in our study to do a site visit when I was there last. And I looked at this and I was like, oh crap. This is a really bad spot for malaria. And this is not a natural swamp. This is dug out from people making bricks. So people dig down, dig the mud. And then you build these towers, you put a fire in the middle of it, fire it for a couple of days, you get mud bricks, but you leave these indentations and they can be 10 by 10 or so. Fill up with rain over time. It's like a mosquito zoo, right? I mean, it's and there's villages in one part of our study area where this is sort of what people do, right? It's just, I mean, in every village, you'll see a few of these, and people do it often for their own homes, but there are some distinct villages in a certain area where this is like what everybody does to make a living. And so it's just sort of a moonscape of these malaria breeding sites. And so thinking about how occupational human use of the land may impact malaria risk is something I think we're going to have to do. This is like a really great site for that thing that you put in, the larvicide you put in the water, right? You've got sort of a fixed location where you know that mosquitoes are going to breed, and you could repeatedly apply it. So maybe that's an intervention there. So I think filling them all back in, I think NIH is going to buy me a bulldozer anytime soon. But again, I also don't know, like, are there behavioral things we could do to sort of change how people do this? And stuck on it right now. So I'm gonna stop there a little early, but just to point out, we have a partnership with the university in Uganda. You can see, whereas most of our work is up here in Kasese, this is Mbarara, the district where our university partner is located. I've been there since 2013. They promoted me to associate professor before UNC did. You can think of it kind of like NC State. So Makerere is the main university in Kampala, and you could say that's the flagship and has been around longer. But Mbarara University of Science and Technology, we call it MUST, was the second public university in the country. It has grown like wildfire. They have sort of all your schools as well as sort of the ag and tech, some of that stuff as well. We will partner with the Department of Community Health there, which has official recognition to transition from a department within the Faculty of Medicine into a separate school of public health, pending sort of government funding. But I think it's going to happen. Mbarara is now the second largest city in Uganda, and it has kind of that feel. So that's mostly our administrative headquarters. We have an office there. It's where we run our IRBs through the university. We have lab space. We've recently built a insectary there, so we rear mosquitoes and things like that. We have a beautiful site out in Boyce. This is our house that we renovated as part of that, as part of our longstanding efforts. Half of it is an office, and the other half are living quarters. We actually have another house on this side as well, and this is on the actual grounds of the health center where we work. So we almost always have three to five students there in the summers. Annika is a epi PhD who's there right now collecting some of her dissertation work. It's great. It's really great to get out. It's a great opportunity for students. It's not all work, right? This is literally on my drive to the clinic. This is not on safari. This is driving to the clinic. I backed up. That elephant was like, come closer, bud. And it's safe, right? We took our kids this summer. So it is very safe. This is actually them on safari. You can see the water buffalo behind. It is 27 hours, so you're gonna take your kids. Consider that. All right, so I'll stop there, take questions. Happy to discuss anything or talk later about if anyone has interest in some of the other data that we collected.
Good about time.
They have questions about it?
Yeah, I was curious. Yeah, really interesting. I was curious if you found any other like co-infections. There were other ones that you were tracking.
We're not tracking any
It's very,
officially.
yeah.
We collected dried blood spots, so we do have samples that are going to be banked
Yeah.
That we could always look into things like arboviruses or things like that.
Uh, would- how regular are the yearly floods and how like variable are the magnitudes of
Yeah.
the flooding that's been happening?
So I'm pulling my hair out because it had been moderate to severe flooding almost every first week of May for the last since 2013. And that was part of how we sold it to NIH. This year, when we launched, has been the driest year in probably 20 years.
Oh my God, next year.
And so we had built in NIH's, like we had built in pause. If it was a freak year, we could pause a year and then launch the next year. Well, what happened this year, right around the time we had to pull the trigger or not, NIH came out and said, we're going to shut down every foreign grant there is.
Yeah.
So what did we do? We said, get out, get what data we can, move.
Yeah.
And so we launched, even though it's been very dry this year, which is disappointing. And then with delays in me having to remove the word climate change from my abstract, our funding was interrupted for a while, so it hasn't been month 1, 2, 3. It's been more like month 1, 2, 4, 5. So it's not working out quite like we had planned. If my program officer ever comes back to work, I may try to get a supplement and say, hey, this was a weird year. Can we get a little bit extra? We already have all the staff on the ground. We have 15,000 people enrolled. Can we repeat it this next year for a sort of fraction of what the total grant cost is? But who knows what's going to happen with that. Overall, the seasons are like a roll of the dice now. It has really made farming challenging. And if you talked, we haven't assessed this. We do have some data in our study that I just haven't looked at. But we're hearing of a lot more malnutrition because people are having crop failures. Because they plant their crops and then it doesn't rain when it's supposed to, or it's hot when it's not supposed to be hot. And so one of the larger hospitals was saying they're running out of like nutrition assistants. They're seeing a lot more kids with malnutrition. And that is 100% due to climate change. It's just unreliable.
I have a quick follow-up
Yeah.
about the flooding as well. Is it like is it happening in the same places and kind of like long-term displacing people from where they used to live? Or people going back and living in the same places and then getting reflooded? And
so much of it is family land and people don't have other options that people kind of go back and start over. Although, as you saw in some of those areas, I've seen places that used to be like matoke, which is kind of that banana crop. Used to be fields of matoke. It's now like a boulder field. You can't farm that. The government has done some things like putting up some river bank, just like stones on the banks. But I mean, my colleague from NC State, who's doing the mosquito side of things, went a few months before me this last trip, and the river was over here. And when I went, the river was over here because it had just totally shifted the course from rains, and that was over a few months. And so you can build and adjust, but suddenly you got riverfront property, right, when they didn't before. Yeah.
So just thinking about the mosquitoes, I know there's research happening in other parts of science that, trying to eliminate mosquitoes through the genetic engineering and all that. And so I just wanted to hear your thoughts on whether there's any sort of, that's hitting this area or is that still too far in the labs and not really in the field yet?
So that Gates has put a lot of money into gene drive mosquitoes, basically making sterile mosquitoes. It's expensive. You have to, how many mosquitoes do you need to generate to breed with all the natural mosquitoes that are out there and not account for the fact that nature is nature, and when you create a gap, it's going to move back in to fill that void. So you need billions of mosquitoes that are created this way, which is one logistical challenge. Obviously, I have an opinion about this. And then they had a big trial in Burkina Faso and they got shut down by the government because people thought they were gonna get mutant animals and stuff. And there was a lot of concern and the government just said, we can't tolerate this pressure, we're shutting this down. And that was sort of their keystone study. And so it didn't go anywhere because they were never really able to do it. I think right now is probably not a great time to be doing genetically modified mosquitoes, even if there's nothing really to worry about from a safety standpoint. I think so you've got both logistical and sort of cultural belief issues that are really going to make that challenge. Yes.
I was wondering, have you looked at all about like inter-household variability within those clusters?
We have not.
So I was wondering like propinquity of their household to these pools of water or
Yeah.
like different income.
We have that data, right? And so as part of our surveys, when the teams go out to a household, they do a search around the home and look for standing water and things like that. And we've looked at things like proximity to the rivers in other studies before. Those are all factors. It's just like anything else. Yes, we tried, there's a lot of similarities in our clusters, but even within that, there's going to be some households that are just higher risk than others. And we do see that. It's one of the things that strikes me so much is here, and then you walk 100 meters that way, and there's just a different mosquito ecology, simply because you've got a big puddle of water or something like that. And I don't know, if any of you live around here, you know that's true. Like I walk into a certain part of my backyard and I get endless grief in my family because I can't get rid of the mosquitoes in our own backyard. I'm supposed to be like an expert at this. So, you know, it's just so heterogeneous from area to area. It's really challenging. Yes.
So great talk. And one of the interesting things about it is that you're talking about sort of flooding as a risk. And you also mentioned pollution as a risk. And generally in the literature, people do one or the other. And so kudos to you for thinking about both, because obviously thinking of environmental effects, they're both potentially there. I don't know, I'm not a physician. Is there any possibility that pollution, that water pollution from the mines affects people's resistance or lack of resistance to malaria? I mean, is there a possibility that these two interact at all?
Yeah, I'm gonna say not being a toxicologist. It's hard, because I can't, you know, I think of like copper exposures, when I'm thinking back to med school. You know, where I think that may happen, it may not be a direct like cell physiology sort of effect.
Mhm.
But if you've got stunting, poor growth, anemia, those things are all going to be exacerbated by each other when you get a malaria infection. Some of those heavy metals, you worry about things like kidney dysfunction. Certainly malaria, when it gets into the severe forms, can trigger that. Like I said, we have never looked at any of this. It's just, and I'm not smart. I have never come up with a good idea. It's just talking to people like, oh, that was a good idea. We should look into that. But talking to them this last time when they were really sort of explaining to us about their worries and seeing the yellow cake sort of dirt, it does make me want to sort of prick some arms and see what levels are in kids in those areas.
It's certainly incorporated in your design in some ways.
Yeah.
To see. Yeah, my connection there is a novel I read not long ago called We Used to Be Beautiful. And it was about people living in a place like this being contaminated by
Yeah.
mines.
Yeah, and I don't think it's going to get any better when they reopen mines.
Right, exactly.
A Chinese company working under Ugandan environmental laws is going to go too crazy on that. Yes.
We were using the test positivity rate,
Mhm.
RDT test positivity rate for your outcome. What proportion of kids are going into health facilities and then getting tested once they get there? And has that really changing over time?
It has, if anything, gotten better over time. when I first started going there, they frequently stocked out of the test kits. I used to have to explain what a test kit was like. And then we had COVID and everybody's used to seeing a little plastic strip. That's what they are. And now they're ubiquitous. And they really don't have stockouts in the way they used to. Where I think we have less visibility is you can go to a drug shop run by someone with no medical training in a, that hut who sells you antibiotics or an anti-malarial for whatever. And you don't need a prescription. They're not going to give you a test. We've done some work about why people do or do not buy a test. Like if you're just going to buy the drug, why do the test? So we think that's probably in the 10 to 20% of drug administrations, right? Because we actually don't know if they have malaria or not. But yeah, in this trial, we're not using the test positivity rate. We're using the outcome as actual kid comes in with fever, symptoms, and test positive. So it's a incidence of what's called clinical malaria. And then we're also measuring what's called asymptomatic malaria. At each study visit, we just test all the kids, even if they don't have symptoms, to see who's harboring parasites. So that's trying to get at it both ways. Yes.
I have sort of two questions, and they're probably both pretty naive, but one is, clearly the nets work, but they're also prone to holes. And then that makes them a lot less effective. Is anybody like trying to develop a net that's less prone to holes? I'm sure it would be much more expensive, but maybe in the long run, there's not as much turnover. But clearly, while the nets are effective, the preventative medicine was even more, like you clearly showed how feasible is the preventative like implementing that just sort of across the board.
Yeah. All right, so nets. So I had two guys from BASF here yesterday. I didn't know BASF is like in RTP, and they make millions of nets each year. And they were saying that Bayer had made a net some years ago that was like polypropylene and was really rugged, but it was incrementally more expensive, so no one would buy it. I came from the Army. I know what lowest bidder looks like on large contracts. And it's challenging. It's not like, a lot of these houses are built like sticks and mud. You've got little sticks sticking out of the walls and these thin, almost wedding bale type materials. And I have young kids. I couldn't keep a net without holes in my house. They're supposed to be good for 3 years, but now when they first came out, it was supposed to be 5 years. And now it was 3 years, and now it's kind of like, well, it's probably closer to 2. But where do all the nets in Uganda come from? They come from the government. And where do they come from in the government? They came from USAID. So I don't know what's going to happen. Your second question about the chemo prevention. I struggle with this because if I go to Uganda, or when I took my kids to Uganda, what did I do? We went to the doctor and they got chemo prevention. Yet all the kids who live there don't get chemo prevention. And some of it is like a not totally incorrect fear of developing resistance, right? And so chloroquine was the drug for decades for malaria, and then resistance developed, and then it took decades to find new drugs, the artemisinins. Interesting story about the artemisinins for another time, but they have a really cool history relating to Mao and the Communist Revolution in China. But people are afraid that if we develop, and we're already seeing resistance in Africa, it's been in sort of the Mekong area, Cambodia and Thailand, but now that it's in Africa, there's a lot of worry. I don't know. It's something I struggle with. From a cost perspective, it would be pretty expensive. From a logistical standpoint, it could be challenging, but it could also be feasible. What if you did it once a month in primary schools, right? Like, it's not that hard. And the drug is not that expensive. we pay on the market like $2 per dose. So is it worth, some people, there's kind of a slide towards being more liberal with it, and you're seeing more studies of it being done in high transmission areas where malaria happens all year. But I have never seen it done of the like, well, let's just give it to kids for 3 years in a row and see what happens.
All right, we gotta wrap there. Thanks to Dr. Boyce. I know I saw a couple people still had their hands up. His office is right over there. He's here all the time, with his door open, so.
Most of the time.
Yeah, yeah. So one more round of applause. Thanks, everybody.